конференцию, международную научно-практическую конференцию «Многопрофильная клиника 21 века. Современные технологии в эндовидеохирургии». Спонсором конференции является компания «Альфамед». «Альфамед» – ваш надежный партнер по инновационным технологиям в мире медицины. Итак, дамы и господа, мы открываем вторую часть. Я с удовольствием хочу вам представить доктора Флемминга Бьёрума, отделение гинекологии, Копенгаген, Дания. Доклад на тему «Принципы симуляции инвазивной хирургии и их практическое применение».
Hello, can everybody hear me? Yeah, good. My name is Fleming Bjørum. I'm from Copenhagen, Denmark, where I work at the Department of Gynecology. I'm currently doing a PhD on surgical simulation, which I've been working with for the last 6 years. Isn't someone supposed to be translating, or is it all right I just go ahead in English? Okay, good. What I want to talk about today is the principles behind doing simulation. I will focus on minimal invasive surgery, and then I will go into the practical implementation on how you develop a training center. First of all, I have no disclosures or conflicts of interest. My funding is from an unrestricted grant and another foundation. The next 30 minutes, I'm going to talk about the background of simulation, the types of simulators we use, the optimal way to use them, and what you have to consider when you're designing a training program. The obstacles we're facing currently in surgical education, and I think that is everywhere in the world, is that there's an increasing number of non-surgical alternatives. And that means there are fewer procedures, so it's harder to reach the same level as proficiency as 10 years ago. There's also an increasing focus on patient safety and litigation, and the demands of the surgeons are also increasing. The role of simulated training is that conventionally all the training, or most of it, has been done in the operating room. And what we want to achieve with using simulators is to move the initial part of the learning curve outside of the operating room. So when you start operating on patients, you don't have to focus on basic skills and instrument handling. The advantages of simulated training is that we can practice repeatedly without risk to patients. It's been shown in several studies that we can reduce the risk of errors during the initial operations. We can reduce the operating time, and we can reduce the number of complications. The last reference, if you haven't seen this is a very interesting study from the United States, where they can actually demonstrate a decreased number of complications after a structured training program. The tools we have available in surgical training at the moment is full-scale simulation, which we can use for non-technical skills and trauma team training. We have virtual reality simulator training, bench models or box trainers, and cadaver training and operations on animals. So we have a lot of possibilities. Oh, sorry, I have it here. So we have a lot of different possibilities, but the most important thing which I want to focus on is that it's not what you train on, it's how you train and how you measure the effect of the training. There are two general things we use to measure improvement. The one is assessment tools. There's a lot of scales being developed in different specialties and for different procedures. And the other one is simulator measurements, where you can have proficiency levels for training, and you can have benchmarks for certification and credentialing. I don't know how many of you are familiar with this one. This is called the OSATs. It's from '96. It was a simple tool to, you can say, evaluate training on a bench model. But this has had an incredible impact on surgical education in our country and in the States. Development of this scale has led to a lot of other scales. This is called the GOLD, which is a focused scale for use in laparoscopic surgery. So it's been adapted to focus more on that. And we've got other scales as well. We have a new one called Gears, which is for robotic surgery, which is quite new. And this one, which is also quite new, which is something different because normally we only focus on the technical skills when we talk about surgical training. This scale evaluates everything in the OR from the moment you enter the door. You can assess how do you talk to the patient, what do you consider before the operation, how do you do during the procedure, and what kind of plan do you do after the procedure. So these things we also have to consider. This is the first scale which covers all aspects. When we talk about simulators, there are a lot of options. Let's see, I can guess. This one is the Lab Sim. This is one we use in our department. This is the FLS, which is the Americans model, a box model, which is the mostly used system in the world. And there are a lot of other possibilities as well. The video isn't showing. Okay, this is, it was supposed to play, but this is an example of one of the basic skills for the novices we use, where you have to train coordination and instrument handling. I'm sorry I can't play the video. And these are some of the skills we start out with. In our training program, we also use procedural modules. This is the examination modules for new gynecologists, which is the removal of an ectopic pregnancy, which we have done studies on to show that it improves operating time, reduces operating time, and gives you a better performance in the OR. Sorry, the videos aren't showing. This is the current level where we are today with surgical simulators. Ideally, these should be able to do everything listed on the slide, but at the moment we're stuck after procedural training. There's only a few procedural modules available, and we haven't really gotten to the part where we can do complication training, but it's coming very soon. Ideally, one simulator should be able to do all of these things, but since we're not there yet, we have to consider which simulators we get depending on our needs. Virtual reality simulators are quite popular, and they have a lot of advantages. They can provide automated feedback. They have a more realistic anatomy than the box models. A few new models have a tactile feedback, so you can feel the force when you use the instruments. And they have procedural training, which is something you really can't do in the box trainers very easily. The box trainers, however, are easy to acquire. They're inexpensive. You get the realistic tactile feedback of the instruments, and you have the possibility to do laparoscopic suturing quite realistically. So there's not one simulator you can say is better than the other. It's a matter of what you want and what you need. If you want to train suturing, then you should have a box trainer. If you want to train procedures, you should have a virtual reality trainer. Yeah, this is just to show you where we currently are and how we can use things. So what I want you to think about is not have to choose between one or the other. I think you should consider getting both. It depends what is your needs, and then get that what's required. This is a study from Canada, where they compared two training programs, one using box trainers and one using virtual reality simulators, and then they tested it in the same setting. And what you can see is that these two, this is the virtual reality, this is the box trainer, they do the same after a training program, so it doesn't matter which one you choose. This is the group who didn't receive any training, and this is the experts. So the message is, it's not so important what you train on, the important thing is that you train and you do it in a structured manner. When you're structuring a training program, there are 3 principles you have to consider. The first is deliberate practice, which was described by Ericsson. The one is distributed practice, and the last is proficiency-based training. And this is quite important because if you follow these 3 principles, then you have a very high chance of success with a training program. Deliberate practice is a theory developed on looking at musicians and Olympic athletes and how do they become experts in their field. And what you define is there are certain criteria you need to consider. The first thing is it's not enough to just say train. You have to have a very well-defined goal and a very well-defined task. The second thing is feedback. It's people training on their own is not efficient. You have to have some sort of giving them feedback on how they perform. That can be with a virtual reality simulator, an instructor, but it's essential. The next thing is motivation to improve. If you don't give someone a motivation, for instance, they can do real procedures afterwards, then there will be no success because they will not train. It's as simple as that. If you don't have a motivational factor, they will not train. And the last things are that you can't just have one task and one level. You need to make it increasingly difficult so they are constantly being challenged. If you just use the same level and the same exercise, they will get bored and they will stop training. The last thing is where the box trainers and the virtual reality simulators are quite useful is that you need to be able to repeat a lot of times. You need to be able to do the same procedure 100 times or 20 times so you can constantly refine and improve your skill. The second principle is the distributed practice, and that's how you structure the program. In many places, both in our country and the rest of the world, people are very fond of courses. It's easy to plan, you don't have to take residents out of the schedule and so on, so it's very easy to do courses. But the problem is that everything shows that you improve skill more if you spread training out over time. So instead of having one day with 4 hours, it's more efficient to having 1 hour per week. It gives better results and it makes more durable performance. Proficiency-based training. This quote is from Lord Kelvin. To measure is to know. If you cannot measure it, you cannot improve it. He wasn't speaking about simulation, he was speaking about physics, but you can apply the same principle to surgical training. If you don't measure how they're doing, you really have no idea how your training program is functioning and if it's working. So it's quite important that you somehow measure and use tools for that, as the ones I mentioned earlier. The reason is that every doctor or surgeon has an individual learning curves. You will have some who have a very steep learning curve, very fast reach proficiency. You will have some who takes longer time, but reach it all the same. And you will have some who don't have the skills and will take a very long time. This person will eventually get up here, but it will take him much more time than these two. Proficiency-based training takes this into consideration. Because instead of just training 4 hours, then you set a goal. You set a level and said, this is the level we want to achieve. And that means that one who has natural abilities, he can reach this in 2 hours, and one who is less skilled may take 6 hours, and there's one who will spend 30 hours. But the benefit is, they all reach the same level. The methods of just saying 5 hours of practice, you have no idea what level they reach and how skilled they become. There's a lot of talk about how you should define these goals and how much should you train. And most training programs, they get to a level as the mark where I'm here because they haven't really tested the system they're using enough. So most training program with a proficiency level, it's around here. A solution to that could be to overtrain, and that means that you set the bar up here so everyone reached the maximum. The problem is you will have some who reach this level very fast and they have to spend a lot of time training, they will spend a lot of time where they don't improve. They will reach the level fast and they will continue training and will not improve despite of using a lot of hours. So what you should try is to find a proficiency level which is close to the maximum. Because this is the ideal point where you want to train people. You want to train people so it's efficient, they don't spend too much time on the boxes, and they spend exactly the amount they need before they go into the operating room. One of the things that's very important is that you don't focus on the simulator. As I said, you can get similar results with different types of training and simulators. So you need to focus on how is the training program structured. There are two quotes here, both about simulation, which says that this is how the results are highly dependent on the manner you structure training. We talk about the surgical curriculum, and a full surgical curriculum should consist of theoretical components, which you can achieve by using skill courses. You should have a technical component, which can be the box models or the simulators in the department. And then you have to have a testing component, so you have to evaluate how are they doing. You have to say, how is this working? Are they getting any better? And the last thing, which is quite important, is that you have to have sort of transfer to the clinical setting. There's no point in having someone training for a few months and then waiting a year before they get to do the procedure. It's completely useless. So if you do a training program, it should be followed up with a transfer to a clinical practice. Another thing is, all of these elements needs to be validated. You can see in the literature there are different tests, there are different training levels you can use, but you need to use some that has been validated. We have a very bad habit as surgeons or gynecologists, that is that three doctors, they decide this is the level we're going to use, but they don't go out and test if this level is relevant, if it had any effect. And if we don't do that, we have no idea of knowing if a training program will achieve the goals we want. And finally, remember, simulator training is just one part of this curriculum. The other parts are just as important. I don't know how many of you know this, but half of all complications in laparoscopy is not associated with instrumentation. It's other areas. So if you want to focus on complication reduction, then you shouldn't focus on the instrument training and so on. There's a lot of other areas you need to focus on. This is our training program, which is mandatory for all first-year gynecological residents, which starts with a one-day course where they get some basic theoretical knowledge. After that, they have to do independent studies, and then they could take a multiple choice test, which has been validated using all the senior doctors in the region. They have to undergo a training program where they show up for how many sessions needed to pass an examination module. And finally, when they've completed the first 3 steps, then they do their first procedure where it's mandatory that they have an evaluation using an assessment scale to see how they perform. And this is not meant to pass or fail them. This is meant to tell them how they're doing and where they can improve. And ideally, this is followed up in the coming months, so every time they've done 2 procedures, then they will be evaluated so we can see how they're progressing. This was completed as a PhD project in 2012. The surgical skills courses, it's not like they're completely irrelevant. They still have use because it's a very good way of getting some theoretical knowledge compressed and making sure they all receive training, receive the knowledge. But it's not very good at technical skills. So if you're doing skills courses, then I would say that you should focus on the theoretical parts of this and minimize, not completely remove, because people enjoy the practical part, but minimize it and spread the training of the practical skills over time. When you try and implement a training program, these are some of the factors that are very important to whether it becomes a success. The first thing is that you have to involve all the key players. It's not enough just to have 2 nurses and 2 doctors at the department. You have to have the head of the department, the head of the hospital. You have to have the logistics, everyone who in some way can obstruct or help the program. This requires a lot of human resources, and I'm not going to say this is easy. It takes an average around 3 years to successfully implement a training program if you start from scratch. Before it's working and everything's functioning, it takes around 3 years in average. Another thing is that we buy a lot of equipment and then we become very afraid of it getting stolen, destroyed, or damaged. So we have a tendency to put it in rooms with locks where we can secure it. Everything shows that if you do this, then the training program will not be a success. If you have equipment for training, it needs to be accessible all the time, so it can be flexible and people can use it. This is essential. And the last thing is you have to have a well-defined goal. It's not enough to say we want a training program. You have to say what is the purpose of this training program? What is it we want to achieve? If we want people to become better surgeons, do we want to reduce complications? And this is very important to keep in mind when you structure the training program. This is a picture from the lab sim, which we use, where you can see there's one of the participants who has passed, reached the proficiency level, and this is how he's performed. And a lot of people think that it's enough to buy a simulator and then we can just stand it and they will use it and train. But we did a study where we looked at instructor feedback. So we had the virtual reality simulator, and then we combined it with an instructor. And this is the results. This is the intervention group who trained on a virtual reality simulator and had instructor feedback. This group trained on the simulator and just used the simulator itself without feedback. And this is the 6 months follow-up. As you can see, there's a significant reduction in training time. That means that these participants, they were a lot faster through the training program compared to this group, and it gave exactly the same results when we looked at their performance 6 months later. And then comes the big question is how much feedback is necessary. This was actually only 20 minutes of instructor feedback we gave them. So this group had the simulator to train, and in addition they had around 20 minutes from an instructor who came over 2 times and helped them and gave them some tips and corrected them and so on. And this is a very small intervention when you compare that we reduced from like 6 hours to under 3 hours. 20 minutes of instructor time. When you're structuring the training program, there are some things that are more important than other things. And this is from a publication from Holland, where they looked at what people thought was most important in training programs. Sorry, I think I'm missing a slide. This is the same slide. All right. This is the things that are less important. But the most important thing when you design a training program is that you have a box trainer. So a virtual reality is really good, and you can use it for a lot of things. But it's essential that you have a box trainer as well. The next thing they found was quite important is that training is mandatory. If you don't have mandatory training, the success rate go way down. And the next thing is you have to have the structured program. If you don't have the structured programs, the success rate also went down. And then there are the final things, you can't see it on the slide, but that is you need to dedicate working hours for training. The model where you say to the residents that they can go and train in their own time isn't successful. You had to be able to train during working hours. That increases motivation a lot. You also have to have the presence of a laparoscopic expert or experienced laparoscopic surgeons. You can't delegate this assignment to someone who has no experience with laparoscopy, a technician, as they do in some programs. You have to have a surgeon associated with the program who can correct and evaluate and improve the program. And the final thing that was quite important is the financial resources. That was one of the most important aspects, that there need to be put in resources to these training programs. It's hardly success whenever you try to implement this without providing resources. These were some of the things that were less important. As you can see, I can't really read the Russian slides, but one of the things that were less important was the use of animal for operations. That wasn't as essential. You don't need to make the program available 24 hours a day. It was enough it was available during the day and the beginning of the evening. You don't need lab technicians as many centers are employing. If you just have a structured training program with booking and availability of the equipment, then that's all right. And one of the things we focus a lot of is awards and so on, as certificates, and that's actually not that important. We have a tendency to think that when you get a certificate, then you've mastered something. But if you haven't assessed them, the certificate is completely useless. The things I want you to take from this presentation is that, first of all, simulators are not a substitution for real operations, but it's an important initial step before operating. The second thing, it's important how you train and that it's structured, but it's not that important what you train on. You can get the same results with low expensive equipment as you can with high expensive. It depends on what you want from the training program. The next thing is that you need to think about these principles I reviewed when you structure the training program. It's quite important that you base a training program on these 3 principles, because that gives the best results. And the last thing is that simulators are not efficient on their own. You cannot just buy the simulator and say we have a training program. You have to integrate the simulator in a full curriculum. Thank you very much. Questions, but we also have a workshop afterwards where I will be if question. But any questions? Good. Then I'll see many of you at the workshop, I think.